Depression, bipolar disorder, these are conditions that affect millions of people. And figuring out how to treat them means going deep into the incredible chemistry of the human brain. So today, we're going to visually break down the pharmacology of the drugs designed to rebalance that very chemistry. Let's dive in and see how they really work. You see, mood disorders really exist on a spectrum. On one end, you have clinical depression, which is so much more than just sadness. It's that prolonged loss of interest, feelings of guilt. And then on the complete opposite end, you have mania. This is a state of intense euphoria, hyperactivity, and, a real lack of impulse control. These two poles are what we're targeting with the drugs we're about to explore. All right, so here's our game plan for this explainer. We're going to start with the big theories behind depression. Then walk through all the major classes of antidepressants, from the newest ones to the classics. Then we'll look at some of the more unique drugs, and finally, wrap it all up with a nice summary. Okay, so to really get how these drugs work, we first have to understand the leading idea about what's actually going wrong in the brain during depression. So let's take a look at the chemistry. So the foundational theory for decades has been the monoamine hypothesis. Basically, it suggests that depression is caused by a chemical imbalance, specifically not enough of three key neurotransmitters. You've got serotonin, which helps with mood and sleep, norepinephrine for alertness and energy, and dopamine, which is all about pleasure and motivation. Now, is it an oversimplification? For sure, but it gives us an absolutely crucial framework for understanding why these drugs were developed and how they work. So how does this all work at a microscopic level? Well, imagine one neuron sends a signal, releasing these neurotransmitters into a tiny gap called the synapse. They float across and bind to the next neuron, passing the message along. But then they have to get cleared out. This happens in two main ways. First, there are these little reuptake pumps, like SERT for serotonin and NET for norepinephrine, that just vacuum them back up into the first neuron. The second way is an enzyme called monoamine oxidase, or MAO for short, that just breaks them down. Remember this process because pretty much every drug we're about to talk about messes with it in some way. Let's start with the most prescribed class of modern antidepressants. These drugs are designed to be really targeted, focusing like a laser on that reuptake process we just talked about. First up, the famous SSRIs, or selective serotonin reuptake inhibitors. And just like the name says, their job is pretty simple but brilliant. They selectively block that SERT reuptake pump, so serotonin can't get vacuumed back up nearly as fast. That means it hangs out in the synapse longer, giving it more time to have an effect on that next neuron. And you've probably heard of some of these. Medications like fluoxetine, which you might know as Prozac, along with sertraline and citalopram, they're all in this family. They're very often the first thing a doctor will try for depression because they work well and they're generally safer and have fewer side effects than the older drugs. Now, here's something really cool that helps answer a big question. Why do SSRIs take weeks to actually work? A newer theory is that in depression, some really important signaling molecules called G proteins get kind of stuck in these little patches on the cell membrane called lipid rafts. Well, it seems that SSRIs also build up in these same rafts, and over time, they manage to push the G proteins out so they can do their job again. It's a fascinating theory for why there's that delayed effect. Okay, next up we have the SNRIs. If you understood SSRIs, this is the next logical step. They take that same concept and just add one more target. So instead of only blocking the serotonin transporter, they also block the norepinephrine transporter, NET. The end result? You get a boost in both serotonin and norepinephrine. And this is a perfect example of how that dual mechanism can have extra benefits. That boost in norepinephrine doesn't just affect mood. It also plays a big role in the pain signaling pathways in our central nervous system. And that's what makes SNRIs uniquely good at treating things like fibromyalgia and other types of chronic nerve pain, right alongside depression. All right, let's wind the clock back a bit and look at the first generation of antidepressants. Now, these are powerful drugs, but as you're about to see, their lack of precision comes with some serious baggage. So, tricyclic antidepressants, or TCAs, get their name from their chemical structure. Yep, it has 3 rings. Now, like the SNRIs, they block serotonin and norepinephrine reuptake. The problem is they're not very picky. They also block a whole bunch of other receptors, alpha, histamine, and muscarinic, which doesn't really help with depression, but it is responsible for a ton of their side effects. This chart really puts it all in perspective, right? SSRIs are highly selective, TCAs are not. This means a much higher burden of side effects with TCAs, things like sedation, dry mouth, dizziness. But the most important difference, the real kicker, is the overdose risk. TCAs can cause fatal cardiac arrhythmias, which makes them incredibly dangerous in an overdose compared to SSRIs. The other classic group is the MAOIs, or monoamine oxidase inhibitors. Hey, remember that MAO enzyme we talked about, the little Pac-Man that breaks down neurotransmitters? Well, these drugs inhibit that enzyme. So by stopping the breakdown of serotonin, norepinephrine, and dopamine, they cause the levels of all three of them to go way up. But, and this is a huge but, with this very powerful mechanism comes an extremely serious risk. And it's why these drugs are almost always saved as a last resort. So here's the deal. That same MAO enzyme is also in our gut, and its job there is to break down something called tyramine, which you find in things like aged cheese, cured meats, and red wine. If you're on an MAOI, that enzyme is blocked. So the tyramine doesn't get broken down. It builds up in your blood and causes a massive release of fight-or-flight chemicals like adrenaline. This triggers what's called a hypertensive crisis, a sudden, dangerous spike in blood pressure that can literally cause a stroke. Okay, after that pretty serious warning, let's shift gears to a more eclectic group of medications. These are the atypicals that don't really fit in the other boxes, and we'll also talk about the absolute cornerstone treatment for bipolar disorder, lithium. This slide really shows you the variety we're talking about. You've got bupropion, which works on norepinephrine and dopamine, and interestingly is also used to help people quit smoking. Then there's mirtazapine, which works in a totally different way by basically cutting the brakes on neurotransmitter release, though it's also known for being very sedating. And finally, trazodone, which isn't a super strong antidepressant on its own, but at lower doses it's fantastic for insomnia because of how it blocks certain serotonin receptors. And now for lithium, the classic mood stabilizer. We're still figuring out exactly how it works, but a leading theory is something called inositol depletion. In very simple terms, neurons use a molecule called inositol to amplify their signals. Lithium basically gets in the way of recycling that molecule. And if the neuron can't recycle inositol fast enough, it can't keep firing at such a high intensity, which we think helps to calm down the extreme highs of mania. But that's not the whole story. A second, equally important idea involves an enzyme called GSK3. It seems that overactive GSK3 is linked to bipolar disorder. And what does lithium do? It directly inhibits that enzyme. This has all these amazing long-term effects. It helps protect brain cells, it promotes the growth of new connections. So it's not just about hitting the brakes in the short term, it's about promoting long-term brain health and stability. But for all its benefits, there's a huge catch with lithium. It has what we call a narrow therapeutic index. This means the line between a dose that helps and a dose that's toxic is incredibly thin. It's a very small margin for error, and that's why patients on lithium have to get their blood levels checked all the time to make sure they're staying in that safe and effective zone. Wow. Okay, we have covered a ton of ground, from reuptake pumps to enzyme inhibitors, all the way to these complex second messenger systems. So let's just pull it all together in one final overview. This summary table is a great way to see it all at once. You've got your modern, selective drugs, the SSRIs and SNRIs, with their specific warnings. Then you have the old school, less selective, TCAs and MAOIs, with their much more serious risks. And finally, you have lithium, with its really unique mechanisms and that critical need for careful monitoring. When you think about it, the evolution here is just remarkable, from simply blocking a pump to changing the fundamental signaling inside our neurons. And it really leaves us with this compelling question for the future. As we understand more and more, how are we going to move beyond trial and error and actually start matching these incredibly specific drugs to the unique brain chemistry of each individual person?